arthroscopy is something which is important diagnostic modality and treatment modality for knee and associated knee problems. All the postgraduate students who are working in different institutions need to be exposed to basics of arthroscopy. And I think this webinar and this lecture would help them to understand the basics in arthroscopy. I'm going to teach the residents in 5 different topics, which is subtopics of equipments, how to position the patient and prepare the patient for arthroscopy, how to enter into the joint and what are the structures they can see into the joint, what are the procedures which are done commonly by arthroscope, and what are the possible problems and complications which can happen while doing an arthroscopy of the knee joint. Understand arthroscopy in addition to knee is also being done for shoulder, elbow, wrist, ankle, hip, and even small joints of metatarsophalangeal and interphalangeal joints as well. So it is an investigation of choice and treatment of choice for most of the diseases of the joint. Most of the knee arthroscopy surgeries other than multi-ligament surgeries are done as daycare surgeries, and often our anesthetist would usually give a TIVA anesthesia, which is also called as a total intravenous anesthesia. This anesthesia involves a syringe pump in which anesthetists usually mix propofol and fentanyl. Propofol is essentially a sedative and anesthetist, and fentanyl is analgesic. These patients go into anesthesia very, very smoothly. They are able to undergo the procedure, which is roughly leading between 15 minutes to 40-45 minutes on a intravenous anesthesia. Sometimes obese patients often also get a LMA, laryngeal mask airway. They go into anesthesia very smoothly and they come out of anesthesia very smoothly with this combination. They hardly have any nausea or vomiting. They are able to become mobile in the daycare unit, and by end of the day, they are able to go home. So daycare surgery, quite safe surgery, and intravenous anesthesia has made life much more easy. The equipments which are essential for anybody to understand arthroscopy and start an arthroscopy are essential 4 hardware equipments. These include a camera, a light source, a fiber optic cable, and a monitor. I think it is important to put all of these instruments on a proper trolley so that they are taken care by themselves. The hallmark of the arthroscopy is essentially a telescope, which is a 30-degree telescope. It's a 30-degree forward oblique telescope. This one is different from the scopes which our urologist and laparoscopy surgeons use. Our urologists often have a telescope which is a 0-degree telescope. 0-degree telescope means you are able to see in the front. A 30 degrees forward oblique telescope makes you see from the front and also on the side. So when you move the telescope, you are able to see all around in the knee joint. There are certain dark areas or hidden areas of the knee joint where you might need a 70-degree telescope as well, but almost all the surgeries of the knee are done by a 30-degree telescope. This telescope length is around 18 centimeters and diameter is 4 millimeter. We have smaller telescopes which are 2.5 and 2.7 millimeters. They are usually used for smaller joints like wrist joint, but this 4 millimeter telescope is good enough for almost all other joints of the body. The telescope is introduced with help of an obturator and a sheath. Sheath will protect the telescope when it goes into the joint, and obturator will help in introduction of sheath inside the joint. The light is illuminated inside the joint by using a light source. A light source can be a halogen light source, a xenon light source, a metal halide, or a LED light source. Halogen is the cheapest light source. It gives a yellow light. The resolution and the clarity is not very great with halogen light source, but almost all the beginners going into arthroscopy practice would start with halogen light source. A xenon light source is a white light. It gives metal differentiation of the colors. It brights the joint much more better. A xenon light source is slightly more costlier and is used in high centers which high volume work. New technology of metal halide and LED light sources are now available. They are a bit more costly, but illumination is much better inside the joint as compared to a halogen light source. When we look into the joint, there are a couple of instruments which will be required for basic knee arthroscopy. A probe is most important equipment which is needed. A probe is also called as extension of a surgeon's finger into the joint. As a surgeon, we are able to palpate the structures inside the joint by using a probe. The probe has got a hook part which is and has got a shoulder part. Probe is used to palpate the structures, to mobilize the structures, like to see for tightness of ACL, and also to probe cartilage, whether the cartilage is soft or injured. Probes come with different graduations. There are marking on the probes. So intra-articularly, you can use the probe to calculate the size of a cartilage defect and also see the size of a loose body, because this would act as a ruler or a scale inside the joint. In addition to probe, other important instruments are graspers and punches. Graspers would help us in holding any loose piece of bone or a cartilage or a synovium and take it out, while punches would help in cutting that cartilage. It is important these punches are used depending upon the size of the joint. There are bigger punches which are 4.5 millimeter punches, and there are narrower punches which are 2.7 and 2.8 millimeter punches. So depending upon which area of the joint we are working, we use different types of punches and different sizes of punches. These punches also come in different angles. They could be a straight punch which cuts straight. They could be an up biter which cuts on the upper side. They could be side biters which cut at 30 degrees and 45 and 90 degrees. And then there are back biters as well. So there is a whole spectrum of punches. Any complete set would have at least 8 to 10 punches of different angles, sizes, and directions, so that you are able to work at different places of the knee joint. Other important unit in equipment of an arthroscopy is a shaver unit. Shaver essentially is a handheld device which is connected to a motor. It works both in a forward and a reverse pattern, as well as in an oscillating mode. The shaver has got two functions. It can suck and it can cut. So there are different types of blade which can attach to a shaver handle. These could be an end cutter, these could be an side cutters, and these could be aggressive cutters. So depending upon the direction in which we are cutting and the tissue which we are cutting, different types of blade are available. Nowadays, there are angular blades also available which work at different angles, and there are flexible resectors and blades available which work in different deeper areas of the joint. We do have extra long blades for arthroscopy in patients where there is a hip problem, because then the shaver blade will be a longer blade which is needed for a hip arthroscopy. I think to start a knee arthroscopy, it is important to position and prepare the patient yourself. We always recommend a pneumatic tourniquet because it has got a timer attached, and you can know when to stop the surgery because you don't want to prolong the surgery too much. Initially in arthroscopy practice, surgery might take a bit more longer time, and there is no harm in doing an open arthrotomy if you think you might cause an iatrogenic damage while doing an arthroscopy surgery. It's important to clean and drape yourself. Arthroscopy surgery has got an infection rate. The infection rate is much less than other orthopedic surgeries, but I think it is important, being an invasive surgery, we have to clean and drape ourselves in a very sterile manner. There are two positions in which an arthroscopy of the knee is done. One is called as a leg by the side position. The leg is on the side, hanging on the edge of the table. So you can sit on the side of the table with the foot on your lap and do arthroscopy surgery. And then there is leg down position, where you break the table and the leg hangs down. So these are two important positions in which surgeries are done. If you don't have an assistant, it is important that you have a lateral post. Lateral post is like a bar which is attached onto the side of the table at an area where the tourniquet is tied. With this lateral post, whenever you give a valgus strain to open the joint, you are able to give a valgus strain without any assistant, because this lateral post will work as an assistant and do a counter force. Your lateral post, in addition, giving a valgus strain also helps you in achieving flexion, which is not possible if instead of a lateral post, you're using a thigh holder. So some surgeons use a thigh holder, it holds the thigh well, but the problem with this is it is difficult to put a figure of 4 position, a position which is needed to see the lateral compartment if you are using a thigh holder, and also you are unable to flex the knee too much when you're using a thigh holder. And in certain procedures, you might need to flex the knee more than 90 degrees. For us, thigh holders are not to be recommended. I think lateral post is much more easier and more friendly to the surgeon to use it. Other limb can be left hanging down, especially if the procedure is small, maybe 15 to 20 minutes. But if the procedure is longer, it is not a good idea to hang both the legs down. A lot of pooling of blood does happen, and patients with a compromised cardiovascular status might have some issues. So you can actually keep the other limb supported. Equipments are always placed opposite to side which we are operating. So if I'm operating a left knee, the equipment are onto the right side. And if I'm operating the right knee, it is onto the left side. Almost all the instruments which are available these days are autoclavable. So you have autoclavable punches, we have autoclavable graspers, we have autoclavable shaver and shaver blades. Even the light camera and the light cable, the fiber optic cable, all can be autoclaved. But you can also use a camera cover. This is a sterile camera cover which is available. It is sterilized by ETO, and these are pre-sterilized camera covers which are available, and you can use these camera covers. There are some surgeons who put the instruments in Sidex. There are some issues with sterilizing instruments for Sidex. Arthroscopy, because has got an infection rate also, Sidex should not be used quite often. Sidex has got 3 problems. First problem is that Sidex is bacteriostatic. It does not kill all the bacteria and it just works as bacteriostatic agent. Number 2, Sidex also has a problem that it does not kill all the viruses, so it's not a virucidal solution. Number 3, which is important, is an older Sidex would always have some kind of growth inside. Most common growth is Pseudomonas. So you need to change your Sidex quite often when you use a Sidex to sterilize your instruments. Also, whenever you have put your instrument in a sterilizing agent like Sidex, when you take it out, it is important to wash the instrument with normal saline before you start using it for arthroscopy. This because if some amount of Sidex which is stuck to the instrument and goes into the joint can cause chemical and corrosive synovitis as well. So these are important precautions if you are using Sidex. But in almost all the centers now with high volume surgery, the entire instruments are being autoclaved and everybody is using an autoclavable instruments. There are different irrigation fluids for you to know. Glycine, normal saline and ringer lactate are 3 important fluids which are used. All these irrigation fluids would inflate the joint, would wash the joint, and the pressure inside the joint is either gravity assisted, which means you have 3 liters of bottle which is put on an IV stand high up towards the roof, and then with the TUR set you are pushing water inside. There are commercially available arthro pumps which are water pushing devices which can push in the irrigation fluid into the joint. More useful for arthroscopies in joints like shoulder where you cannot apply tourniquet. Less commonly used for knee arthroscopy. Advantage of glycine is that in addition to doing an arthroscopy, if you have to use a cautery device, you can cauterize it. Though again in the knee, because of tourniquet availability, you don't need to use too much of cautery device, and henceforth we don't use glycine too much commonly now. The problem with glycine is also intoxication. In older patients, especially with problems with hypertension and cardiac issues, if you use too much of glycine, some amount of glycine is absorbed into the fluid and blood and would cause cardiac overload and issues with patient with cardiovascular compromise. So our fluid of choice is normal saline. You can use 3 liters of normal saline bottle, which can be hanged onto an IV set, connected with a TUR set, and irrigation does happen. In the normal saline, we can always use a radio frequency device, which is something like a cautery device, but works on a principle of radio frequency, which would help us in oblating the tissues inside the joint and also in cauterizing leaders inside the joint. Ringer lactate is much less commonly used. Most commonly fluid which is used is normal saline. Back trolley is important. In addition to your power system and arthroscopy hand instruments, you also have some sharp instruments which are to be kept separate, because these knives and blade may cut costly equipments and cause damage. There are reconstruction sets which a surgeon might need to understand and learn depending upon the type of surgery. Like an ACL reconstruction has got a different reconstruction set. We do have a PCL reconstruction sets, a cartilage reconstruction sets, an MPFL reconstruction sets, and other ligament reconstruction sets available. However, for beginners, I think it's important that they have a good, excellent quality of optics and a power system and good hand instruments to start doing arthroscopy surgery. As I said, arthroscopy is an invasive procedure. There are infections which have been reported, though a lot of irrigation fluid is being used, so chances of irrigation and infection are much less. But I think sterility has to be maintained as if you are doing an arthroplasty procedure. You must paint and drape the joint yourself. It is important to use waterproof drapes. If you are using our normal cloth drapes, there are chances that sodding of the surfaces might happen, and this might cause contamination. We are often using waterproof drape, and these are commercially available. Lot of these waterproof drapes are available with water collecting pouches. So whichever water spills out of the joint, they don't fall on the floor, but goes into a water collecting pouch. And through the pouch, there is a tube which goes into either a suction or to a drainage. So this would help in cleaning clear areas and does not contaminate the field. When you drape the patient, it is important to drape yourself as well. Whenever a surgeon is doing arthroscopy, especially in a sitting position with the leg on the side, the foot of the patient is actually usually on your thigh of the surgeon. In such circumstance, your own gown should be actually draped till the toes. If you have a shorter gown, it is ideal to put a sterile sheet over your groin so that you are completely covered by a sterile drape right from your neck right till your toes. So even if some kind of contamination can happen, it would be much avoided. It's important to drape patient yourself, clear the medial side and the back of the knee. Lot of surgeries are done on the back of the knee as well. Contrary to the belief that arthroscopy essentially is a surgery on the front of the knee, we do lot of procedures in the back of the knee, especially removing the loose body from behind, doing synovectomy in the back of the knee, doing ligament reconstruction like PCL also in the back of the knee, and repairing meniscus tear, especially the ramp tears in the back of the knee. So when you do a draping yourself, medial side should be cleared, and on the posterior side of the knee also should be clear, and there should be no drape sitting and stitching to the back of the knee. There are conventionally two essential portals which are needed. This is a portal wherein there is an anteromedial portal which is also called as an instrument portal through which our instruments would go. But a clever surgeon would keep on swearing, which means you should be able to switch your scope from the lateral portal there. You would see more anatomical details much more better when you start seeing things from different angles. There are other portals which are there, superolateral portal, which is essentially used for suprapatellar pouch. And then there are posterior portals, which are posteromedial and posterolateral portals, which are essentially used to work in the back of the knee. But for the beginners, anterolateral portal, which is an arthroscope introduction portal, and anteromedial portal, which is an instrument portals, are more important to understand and learn. That's a small arthroscopy picture. We do a surface marking, always mark the lower pole of patella, patellar tendon, and ligamentum patelli. And then this is a small stab incision which is given on the anterolateral surface. A trocar and sheath is introduced. Irrigation fluid is connected, fluid is pumped in, and then telescope is connected, which is covered with a sterile camera. Once this is done, you are able to make a second portal which is parallel to the first portal, and you are able to see inside the joint. You are able to see the femoral condyle above. You are seeing meniscus. There is a probe which is going in and it is palpating the meniscus. The tibia is down, and with the probe you are able to hook into a tear there in the meniscus, and that's an unstable meniscus tear. So these are important structures which are seen initially as you go in. You are able to see the cartilage, you are able to see the meniscus, you are able to see anterior cruciate ligament, and some of these structures one should be able to palpate and see easily in the first go. As with all surgeries, systematic examination of the knee joint would help you miss not any pathology. You always start with suprapatellar pouch, then we go to the medial gutter of the knee, then we look into the medial joint, come to the intercondylar area, then to the lateral joint, lateral gutter, and finally we look into the back of the knee. In the suprapatellar pouch area, you are going to see for patella. You are also going to usually see for synovitis and loose bodies in the suprapatellar pouch. In the medial gutter, there is usually either an MCL tear which can be understood and seen, or there could be loose body inside the medial side. And the medial joint usually has a meniscus tear or a medial cartilage damage. Intercondylar notch area has got ACL and PCL ligaments to be seen, and then lateral joint has got usually a lateral femoral and a tibial cartilage and a lateral meniscus. Lateral gutter is the area where most commonly loose bodies are lodged, and then as we told, posterolateral and posteromedial areas are the areas where you may find loose bodies, you may find synovitis, and you may use these portals for accessory work like PCL reconstruction and ramp repair as well. I think these are important three structures. To understand pathologies and of these three structures are important for arthroscopy. When you start doing arthroscopy, the vision will open up because you would be able to see so many things in a beautiful magnified manner, and your diagnosis would become much more better. Meniscus, ligament, and cartilage are three important structures. You should be able to see normal structures and identify torn areas and do some procedures with these three. This is a bucket handle tear. I think bucket handle tear is the most common meniscus tear where the patient comes with a locked knee. This usually is an urgent surgery because patient is unable to extend the knee completely. These bucket handle tears are usually also associated with ACL tears. These are big fragments, and we should not cut and throw these fragments. We must try to repair these bucket handle tears. Younger the patient, the chances of repair are much more higher, especially in a bucket handle tear, which is usually detachment from the periphery of the meniscocapsular junction. Other tears are cleavage tears. These are split tears like these. They are commonly seen in degenerative knees, but are also associated with meniscal cysts. So if you have a patient with a meniscus cyst, you have a cleavage tear like this. You have to decompress the meniscal cyst by cutting from going from inside between the cleavage and decompressing, and then you can manage the cleavage tear by either resecting one part of the unstable fold of the cleavage or even sometimes repairing the cleavage tear up to down. Another important tear is a flap tear. It's like this. Flap tear are very, very common tears. These are the tears which actually cause a lot of locking and instability. It's a flap of tissue which is coming in between the bones. They also cause recurrent synovitis and sometimes also sound in the knee joint. Flap tears are the most important tears where meniscectomy is the solution. You can't repair flaps. You have to excise the flaps. So depending upon how big the tear is, you have to use your punches to either do what is called as a nibbling, remove it small piece by piece, or remove it completely en bloc, these flap tears. So flap tears are most common tears which are used where meniscectomy is done. There are in addition also meniscus root tear. Meniscus root tear is a hidden lesion of the knee joint. What we are doing is removing the fat in front of the PCL, and then through a small window between the medial femoral condyle and PCL, we go towards the back of the knee, and there you find a tear there. This is a meniscus root tear. A meniscus root tear is a tear which, when happens, the meniscus loses the hoop stresses, it becomes dysfunctional, and it actually behaves like a total meniscectomy. To bring the root back into the place from where it is torn is important, and this is called as a meniscus root repair. We also do repair peripheral meniscal tears. These tears should be in the red zone, which is the peripheral vascular areas. We use either all inside out, or an outside in techniques to repair. The suture material is usually a non-absorbable suture. So here you find there are needles which are going from inside the knee. There is a small stab incision made on the posterior medial aspect. The needles are going then outside. Slowly we are taking the needles outside. So you are able to actually put stitches into the meniscus and the repair the meniscus. So this suture is now being pulled out and you are able to stitch the meniscus from above down. So this is a vertical meniscus repair. You can also do a repair which is down, which is also called as a something like a transverse meniscus repair. So that's another kind of meniscus repair, which is an undersurface of meniscus. So you can reattach the meniscus by putting either a vertical stitch or a transverse mattress stitch. So you're able to repair it. But important of a meniscus repair, it has to be the tear in a red zone. The suture materials are non-absorbable suture. The techniques can be different. All inside technique is essentially used for the posterior horn. Inside out is used for the body, and outside in is essentially used for anterior horn tears. In addition, there are patients where you have ligament laxity. The ligament laxity are secondary to ligament injuries. There are patients with lot of instability. It could be ACL or a PCL injury. Not going much into detail, but arthroscopy gives you an insight to diagnose and reconstruct these ligament injuries and make the knee stable. You can do either use an autograft or an allograft or a synthetic graft to do reconstruction surgeries in the knee. Autograft essentially use hamstring or a bone patellar tendon bone graft. We also use sometimes quadriceps tendon graft to repair ligaments inside the knee. And some of the surgeons are using a tendon from the ankle, which is a peroneus also, to augment the repairs. So these are either arthroscopic surgeries or arthroscopic assisted surgeries where you are putting synthetic grafts or an autograft, or in a condition where you have multiple ligaments which are torn, you might also use an allograft, which is a cadaveric allograft. So multiple reconstruction options are available. Arthroscopy gives you an insight, give you isometric points from where the ligament could arise and insert. And then with these isometric points, with different techniques, you can either make small sockets and drill in tunnels and pull in grafts and fix the grafts with bioabsorbable implants or PEEK implants or even titanium implants, and manage ligament reconstruction surgery to make the knee much more stronger. In addition to the knee, as I told you, there are cartilage lesions which are also there. This is patient which has got a cartilage tear. You can use shaver blades, as I told you, and do what is called as a superficial chondroplasty. So you can remove all of these loose pieces from inside the joint, and then finally when you come to the cartilage base, you can either debride that cartilage, make it smooth, or make small punctures into the cartilage, which is called as microfracture, which would allow pluripotent cells from the bone marrow to come to the cartilage surface and help in regenerating the cartilage and putting a fibrocartilage layer over this. Often sedentary patients who are not into athletic activities, do very well by superficial chondroplasty and microfracture. Athletic population and those with bigger defects, we often do osteochondral grafting and ACI. ACI is chondrocyte implantation. Now these are advanced techniques in arthroscopy, where a small piece of cartilage is taken, send it to the laboratory to grow cartilage cells and chondrocytes, and then they are re-implanted back after around 6 weeks or so on a large cartilage defect. And this is then protected for a long time so that the cartilage regenerates well and patient is going back into sports. However, in sedentary household patients, only debridement, microfracture and chondroplasty is good enough. We do have new techniques now, which are radiofrequency devices, which are actually commonly used in the shoulder, but also used in knee, especially in superficial chondroplasty of the small cartilage lesions, arthrolysis in a stiff joint, and sometimes even in synovectomy. These radiofrequency devices work at a low ambient temperature. They do not heat up the joint fluid. They do not cause the cartilage to get damaged, but we can work inside the joint without raising the intra-articular temperature and does not cause a chondrocyte damage, which would happen when you use a cochlear devices. So now radio frequency devices are used in knee also to a certain extent, especially if you have superficial cartilage lesions. If you have a stiff joint, you can remove the fibrous adhesions with radio frequency rather than a cautery. And in patient with fulminant synovitis, you can do a synovectomy with shaver, followed by using radio frequencies, because then these patients will not bleed too much. Finally, there are certain problems which beginner would face. This problem is poor visibility, and these are four important outs which must be understood and remembered. One is called red out, yellow out, white out, and black out. Red out means when you put a telescope, everything looks red. This means there is some kind of hemarthrosis which has happened. So you have to recheck your tourniquet, increase the fluid inflow, wait for some time, let bleeding stop. There should not be too much of turbulence inside the joint. And once the fresh fluid goes inside, red out would eventually stop. Yellow out means your telescope is inside the fat pad and you would see everything like yellow on the screen. So you have to withdraw your telescope, put your sheath and trocar again and reintroduce it so that you are out of the fat pad. Also, it is a good idea to introduce your instruments and equipment slightly away from the center so that you are not into the fat pad. White out is a picture where everything looks white. You can't differentiate what is what. This happens when fogging happens. There might be humidity, the temperature might be different in theater and in the joint, and there could be a leakage in the camera cover which is using. This causes fogging in between your camera couple and also the telescope. This is called whiteout. You might need to open the camera cover, change the camera cover, and take care of the whiteout. And blackout usually happens when there is some short circuit which has happened and everything just turns black. So you have to have a USB device or a backup generator whenever you are doing an arthroscopy. Other important things are cartilage injuries and instrument damage. I think arthroscopy is a technique where you're looking somewhere onto the monitor and working inside the joint. This is a highly skilled job where cartilage damage, if does happen, is an iatrogenic damage. Cartilage damage would be permanent of the joint and scuffing of the cartilage would cause early arthritis. Also, if some amount of instrument does break inside the joint, it becomes a disaster because loose small piece of broken jaw of either a punch or a grasper can go anywhere into the joint, and then this surgery becomes a big havoc. So I think initially all the surgeons who want to go into arthroscopy must undergo some kind of cadaveric training to do these surgeries gently. And Indian Arthroscopy Society, along with the national societies, do a lot of these cadaveric workshops, which would help young arthroscopy surgeons to learn the techniques of arthroscopy. I think with this, I must end my talk because it is more or less an insight into what is arthroscopy, what are the things which you can do by an arthroscope, and what are the problems which young person might find when he goes into a technique-based surgery called as arthroscopy. Thank you very much.